me for inviting me to be one of the keynotes of this conference of HIS 2022. It's a real pleasure. So I would like to thank the organization and in particular Professor Wong and Professor Ahmad Raina, which they contact me for this keynote. So well, as Professor Wong said, I am full professor at the Universidad Politécnica de Madrid in Spain, where I am leading a laboratory that basically what we are doing is applying data-driven approaches, mainly artificial intelligence, machine learning, etc., approaches to biomedical data. Okay, so in this context, we have several projects that are dealing with different approaches or different perspectives, some of them natural language processing, some of them more creating predictive and descriptive models. And part of my research, my closest and my more recent research is about the use of computational approaches for trying to create drug repurposing hypotheses. And this is what my talk will be about. The title is Data-Driven Drug Repurposing Hypothesis using heterogeneous types of data, the DISNET approach, and DISNET is the name of the project in data that I will explain later. So, well, first of all, right now we know that exists around 24,000 catalog diseases, okay, but we only have drugs or treatments for around 1,500. These are rough numbers that, of course, are evolving every day. New drugs appears and new drugs are approved and can be used, but this is more or less rough numbers. But even in many cases, we don't have even palliative treatments, okay, because most of these drugs that nowadays we have are used not to cure the disease, to treat the symptoms, okay, are palliative treatments. But even palliative, there are many diseases that they don't have any treatment at all, okay, and this is because even these palliative treatments are difficult to be found, okay. So there are several problems behind that. With respect to the data, we have a lack of information and knowledge. Part of the required knowledge that we might need in order to investigate a little bit more about this is not available or it's difficult. There are secondary problems, like we have different databases, different silos of information, different interoperability problems, restricted access. We probably all found that we are trying to make maybe a comparative or methods against a given data set, and the data set is not available or was published several years ago and now is gone. So data-driven approaches are difficult to apply due to data heterogeneity, okay? And on the other hand, this data heterogeneity, these different types of data, the diverse types of data are probably one of the most important issues here. I just would like to introduce you the approach for those of you that are not familiar with the creation of a drug, of a medicine. What is the process? And basically is that from different stages, since we identified the compounds that can be used for creating a drug, until we have one final compound that will be approved by the regulatory bodies, we have near to 11 to 17 years in average of time. And we have an expenditure and expenses of around 1,500 and 3,000 millions per drug, $1 million, which means that it's a huge amount of time and a huge amount of money, and only to get finally one drug. So there is an alternative to this approach, that is the approach, it's called de novo development in drug development, that is trying to do what is called drug repositioning or drug repurposing. But the idea is that with the current knowledge that we have and with the treatments that we already know that are working for given diseases, trying to find a new use. So we have a drug that is used for one disease. Can we use this drug in another disease? That's the question. And it's what drug repurposing is trying to do. And this reduces the time, reduce the risks, and reduce the cost. So it's a win-win situation, okay? This is a comparative of some of the stages that takes the novel development in the first part, the A, versus the drug repurposing or drug repositioning. So we can see that there are some phases that can be removed, and there are other phases that can be reduced in time, okay? So some phases, for example, like, I don't know, the drug development itself can be reduced from 5-6 years to 1-6 years, okay? So there are some of them that are the same, licenses, this is bureaucracy, it's administrative, but there are several others that can be reduced, and this is really important. In drug repurposing, there are several approaches that can be executed. One is the disease-based, where we have one drug that is specified. I mean, it's expected to be against one target. That is part of what we call the original disease, and we try to find a new disease based on the similarities between these two. In the second one, in the target base, we have one target, but this target belongs to two different diseases. So we try to discover a new disease which has the same target. And in the drug base, we have directly two targets, one compound that can be used, for example, for the inhibition of certain proteins, two different proteins, two different targets, two different diseases, okay? So these are the main three approaches that we have in drug repurposing. And from the computational perspective, that is the one that I would like to discuss today, we have many computational approaches, but two of them that I think that are quite relevant and that are some of the ones that are more, more close to my work are this pathway mapping and the artificial intelligence one. The pathway mapping, that it's more based on trying to find or trying to do a network analysis on the genetic protein or disease data to predict potential drug repurposing candidates, okay? And trying to find potential targets detection, okay? So it's when we go back here and we go to this approach of target-based, okay? Target-based. So there are many examples of drug repurposing cases. Probably you know some of them. We have the first two, the duloxetine and retinoic acid. For example, duloxetine was originally used for depression and now is used in urinary incontinence, or the retinoic acid that has been used for acne and now is used in leukemia. But there are two that are probably more known, that are the sildenafil. Okay, the sildenafil was a compound developed by Pfizer that was originally trying to be used against angina pectoris and now is used for erectile dysfunction. And the second one, that is the thalidomide, that sadly has been very popular because it was used for nausea and vomiting, especially in pregnant women several years ago. And this drug caused a disease in the babies that was called phocomelia, that is a deformation in the babies, okay? And was completely retired, of course. But now there is a new indication that is leprosy. And I read some recent studies that it's also trying to be applied in some type of cancer. So we have examples, many examples that this can be done, and this is the important thing. So for a main approach, the main approach that we are pursuing in my work, in my project, is trying to apply network approaches. I will skip this slide fast, because probably we all know what is a network, we all know what is a graph. Basically, we have elements that are connected across them based several nodes based on links and relationships. So this network approach is the basis that we are going to use in this context. So I would like to explain a little bit what is a human disease network. I don't know if you are familiar with this concept, but this concept was proposed originally by a team that is in USA. Right now they are in Northeastern. It's from the team from which is a physicist, very, very well-known physicist in network science. And they published a paper in PNAS in 2007, where they proposed the human disease network. Basically, what they proposed was something that we already knew, okay, but from more a computational perspective, that is trying to relate diseases with genes, okay, if there are some mutations in the genes that allows to make this association. We know many cases in many diseases. Right now, these mutations are used as biomarkers, okay? So depending on a certain gene that we know that there is a mutation, we know that there is a higher chance of developing a certain disease. Typical example in breast cancer with the BRCA1 and BRCA2 genes, for example, but there are many others in many other diseases. So basically what they did is that they create this type of structure where we have diseases and they are related with genes, and depending if two diseases are sharing one gene, basically these two diseases are connected. So we have here the example, for example, disease one, that is, it's in Spanish is A1, A2, A3, with G1, G2, G3. So A1 and A2 is related with J1, which means that A1 and A2 are related, are connected, okay? And with this approach, they create the human disease network, that is basically diseases that are related across them, and the line or the connection between these two diseases can be thicker or stronger depending on the number of genes. Okay, so as much genes, the connection is stronger, which means that they are more related. So this is really interesting, but they extended the approach and they go to the phenotypes, to the symptoms, and they publish another paper in 2014 in Nature Communications that relates diseases and symptoms. So a connection between a disease and a symptom is done if they have symptoms in common, and we do the same approach, okay? And we have here that, but using the symptoms instead of the genes, we can connect diseases. And with this paper, they create a variety of connections that go farther from the genes, farther from the symptoms, and they propose, for example, some things like protein-protein interactions. So we know that one gene codifies one protein interacts with another protein. Depending on the protein-protein interaction, we can have also connections between two diseases, not based on the genes, not based on the symptoms, but based on the proteins that are codified by such genes. And this allows to create a network of diseases that can be connected across them using different characteristics, and each characteristic or each feature will have different weights. And this is really interesting because it allows to create a network of information about diseases that allows to see the molecular interactions that they might have based on the characteristics. And this opens the question of, first of all, how similar are two diseases, depending on the features that they share at biological level, proteins, genes, protein-protein interactions, pathways, okay, or at phenotypical level, symptoms. And with this idea, we can go to the hypothesis. If drug X is used to treat disease A, and we discover that disease A and disease B are similar, based on these similarities, on these features, can we use this drug X to treat the disease B? So based on the similarities, can we hypothesize about the use of a given drug in a new disease? That's the question that we are asking, and that's the answer. Yes, of course, between commas, there are many things that needs to be taken into account. But yes, there are evidences that have shown that the connections that exist between two diseases can be used somehow as predictor of if a given drug could be used in a new disease. And this is what we did, okay? And this is what many people is doing indeed. I mean, many researchers, I found every week, I don't know, 10 new papers of that from across the world, from USA, from China, from Europe. There are many many groups working on that, and this is really interesting because it's attracting attention, and this is because there is something behind. So there are other advantages of these human disease networks. We can get a greater and better understanding of the causes and effects of the diseases. We can find patterns that don't appear in individual studies. If we focus on a disease, that's great, but there are patterns that are in many diseases, okay, that can be found in many diseases when we are analyzing groups of diseases, okay? We can identify new treatments, targets, and biomarkers. We can establish disease modules. This is really important. There are many groups working on that, on the idea of the disease module. So we are no longer following the idea of one disease is one disease. No, we have disease modules that are basically interactions that occur at molecular level. And these interactions, the group of interactions are this disease module, okay? So we are no longer talking about diseases. And this is important also because we are no longer talking about the typical categorization of diseases. We are no longer talking about, I don't know, ICD from World Health Organization. We are no longer talking about the SNOMED. We are no longer talking about disease ontology. We are trying to redefine the diseases not based on the organ that it's main where they affect. We had the example on COVID. Yeah, COVID was mainly considered a respiratory disease, but not only. I mean, there were many systems affected, okay, at a neurological level, circulatory level. So there are many evidences that show that COVID is influencing on cardiovascular effects, okay, after that. So it's not just respiratory, okay? And this happens with many diseases, okay? So we can create new disease classification models using these approaches. But we are not. I am not going to talk about that. I am going to talk about drug repurposing. And here we come to this name of DISNET. What is DISNET? DISNET is a project that was funded by the Spanish Ministry of Science. It's called Disease Understanding through Complex Network Creation and Analysis. We get funding from this Spanish government and also from Madrid region in a doctoral, in an industrial PhD program. And basically, DISNET is a platform that was developed to acquire biomedical knowledge from public sources. What we do is that we create a set of computational methods that allows to get this knowledge from the sources and keep it and save it in a database. In a database that is composed by 3 layers in what we call multi-layer network, that I will show the structure now. And the platform is publicly available online. So if you are interested in using it, please go ahead, go to this URL, disnet.ctv.upm.es, and you can go, you can check all the papers that we have published. You can check the access to the data. We have a REST API. You can work with it. You can play with it. Please, we will be more than happy if you do it because we did this for the scientific community. Okay, and the information is structured on these 3 types of elements: phenotypic, biological, and pharmacological. Okay, and depending on each of the layer, we obtain the data from different sources. I will go a little bit fast about from the layers because it's more descriptive. But for example, in a phenotypic layer that I think is one of the most interesting, we store knowledge about symptoms, signs, and other manifestations of diseases. What we use is a text mining approach. Concretely, we are right now using MetaMap that is developed by the National Institute of Health in the United States. And it's an approach that allows us to work on to extract information from text approaches. We have 3 main sources. Okay, one is Wikipedia, one is PubMed, and the third one is Mayo Clinic. Okay, and in Wikipedia, most of you can think, "Oh, Wikipedia, really? Are you using Wikipedia?" Yes, I mean, indeed, I understand that you might not trust on Wikipedia, but we did several analysis, and it's working. And it's working. And what I mean with it's working is that it's trustable. I mean, we get information from Wikipedia we get information from scientific papers, and we saw that it's more or less the same, okay, in a set of different papers. So what we do basically is that we go to the Wikipedia webpage, we select a specific section of the Wikipedia text, this is signs and symptoms, and many others that are related, and with this, we get the information about the symptoms. And with this information about the symptoms, what we can create is something like that. We have two diseases with the symptoms that are in common and the symptoms that are disjoint. And this, we apply it every 15 days to Wikipedia, to PubMed, and to Mayo Clinic. Well, to PubMed is not every 15 days because it's much larger, but Wikipedia and Mayo Clinic every 15 days. So every 15 days, we are able to get information about these diseases, and we are able to see how they evolve. We are able to see how they change. We are able to see many, many interesting information, not only in the perspective of how the diseases are defined, but also in the perspective of how the diseases or the information about the diseases is evolving. This was really interesting, for example, with during COVID, during the hard times of COVID. We are still in the pandemic, but during the hard times of COVID or the harder times, we were able to see how the information about COVID was evolving. And this was really interesting, okay? It's not just about the information that we can get, it's also about the information that we produce as humanity. And this is, in my opinion, really interesting. So we did this, we get this type of information. In the biological layer, we have mainly three elements that we have more indeed, okay? But these three elements are the base: genes, protein, and pathways. And we get it from this type of sources, DISNET, Wiki Pathways, and NextProt. As I told you, we are getting more information. We are now working on sequences, on protein sequences and gene sequences, amino acid and nucleotide, to extract and to work with this information. We also have some circular RNA information. So we have many types of data, and these are a summary of the data that we have, near to more than, indeed, 24,000 diseases cataloged from a biological perspective, several gene disease associations, several protein-protein interaction associations, pathways, metabolic, human metabolic pathways, gene pathway associations. We have many information that we are exploiting. And in the pharmacological, in the drug layer, we have chemical structures, therapeutic targets, as well as phenotypic effects. And we have these sources: Chambel, CIDR, CTD, Drug Bank, SNORM as the main ones. And again, we have, for example, more than 60,000 drug phenotype associations. Please, I mentioned at the beginning, there are only 1,100 or 500 treatments. Yeah, because we have this type of treatment, but we have much more associations because, for example, there are many drugs that can be used for many diseases because they are general. If we are talking about paracetamol, for example, this anti-inflammatory, no, antipyretic, okay, analgesic, it's used in many, of course, in many diseases, okay? And well, going to a more computational perspective, we have this type of information. In phenotypical, it's the larger, near to 80 million rows of information, and near to 20 gigabytes. And our system follows this architecture. Basically, what we have is a system that extracts the information. We can see it here from the sources. Using the NLP process, we get the information in more structured way from these biological and these pharma sources. We integrate everything in a single database, and we give access to you, to the scientific community, to exploit this data, okay? Finally, what we have is this sort of a structure where we are able to see the main representation scheme, okay? This main representation scheme is divided into 3 layers, and this allows us to do many things, like, for example, trying to get definitions in terms of phenotypical descriptions from different sources, using intersection, using union. So this is really interesting because it allows to see how the description of one disease changes across sources. And it's really interesting. How can be that, and of course we have an explanation, but how can be that the description of the influenza in one paper is different from the definition of influenza in other paper. Of course, there are many factors there, environmental factors, of course, population factors, even the population that has been under study. It's not the same. There are diseases that are not behaving the same in different countries. We know that there are diseases that are infectious diseases that are more prevalent in certain areas because of the temperature, for example, or because of the climate. Okay, so this is normal, but also the genetic diseases are different distributed. We are an interconnected world. But the reality is that there are certain, let's say, mutations in genes that are more prevalent in certain areas because there is more endemic how the population is growing. Okay, and it's more difficult that these mutations go out of certain areas. So it's normal. I mean, same disease can behave different. Okay. So at the end, what we have is a public platform. I will skip this very fast, that allows you to go and visualize the data. You can go visualize here by disease. You can select one source, one snapshot. I told you that we create data every 15 days. So every 15 days, we create a different snapshot. You introduce the diseases. You want to see the symptoms in common. For example, in this query was a comparison between COVID-19 and AIDS, okay, and HIV. And we have symptoms in common, we have the symptoms that are not in common. We can do a search by symptom, we can introduce all the symptoms, and we can get all the diseases that have these symptoms in common in a visual and in a table way, okay? And this has an API and allows to be queried by you, by the community. Until here, I have shown you basically what is DISNET in terms of extracting information. But I didn't talk about drug repurposing at all yet, because DISNET was, the first objective of DISNET was to create the infrastructure that allows me to get data from public sources, heterogeneous sources, integrated in a single element that allows to create this type of network structure, even considering that we are using a relational database for the sake of simplicity in the storage. But at the end, the network approach is easily can be easily extracted. Okay, and with this information and with this data is when we can start doing drug repurposing. And here are my last slides, and I will show you two cases where we have applied or we have used the data that we have, in order to try to create drug repurposing hypotheses. So the first one is this evaluation of DISNET as a tool for drug repurposing. I will give the details, high-level details. So if you are interested in going in depth, here is the paper where we have published our results. Okay, in the DISNET webpage, you have all the papers. But basically, this is the paper, data-driven methodology towards evaluating the potential of drug repurposing hypotheses. Okay, so basically, we consider here to evaluate how appropriate DISNET was able to be used for this drug repurposing. Okay, so what we are aiming is that we have a drug, we have a disease that was originally used in this drug. I mean, this drug was originally used for this disease, and we try to predict if there is a new disease that can be used with this drug. So what we created was this schema where we have a drug repurposing case, drug, original condition, new condition, or original disease, new disease. And from this, we create triples, okay? That is basically the drug based on the internal name that we have in DISNET and the Chembel ID, okay? That is basically it's going to tell me the targets of the drug. We have the original disease with different schemes of codification. For example, QUI, that is very common to be used in UMLS, in Unified Medical Language System. But we have also our own DISNET ID, and the new disease with the same. So at the end, what we do is basically something like that. Imagine this case, required is the drug, the original disease is Parkinson, and the new disease what is used is restless legs. Okay, in our database, this goes that one case of drug, original disease, new disease goes to 2 triples. Okay, required, same ID, but in the Parkinson disease, we can see that we have Parkinsonism in the first triple with 1 ID, and Parkinson disease with different ID. Okay, but the restless leg syndrome is the same. Why is happening this? Because as I told you, we are using different approaches to get information from symptoms and different sources. And in each source, we might have this definition of the Parkinson with different IDs and with different names. Parkinsonism and Parkinson disease is the same, but in our system has been divided because the different sources divided. But we are able to know that are the same. We have approaches for that. So with this approach, basically what we do is that we got 3 papers, we get several cases that were identified as drug repurposing, and we made a filtering, okay, that finally, and this is the important thing, the filtering basically removes elements that we didn't have or something like that, and we finally have a total of 79 cases that were able to be analyzed, okay? This was translated in this number of triples, drugs, and diseases. The final number of triples is 247, with different drugs 40, original disease 34, and new diseases 53. And here is what we did. Okay, once we have this data, what we did is that, okay, we get from the original disease and the new disease of a given drug, we get all the elements that are in common in terms of genes. Okay, so basically we get the gene, in this case typically is 1 gene, okay, the gene that is shared by both diseases, and that this gene encodes the protein that is the target of the drug that we are aiming to study. So remember, drug, original disease, new disease, this is the drug, okay, the reposition drug, original disease, new disease. And what we are doing is trying to find the genes, okay, that are in common in these 2 diseases that codifies the protein that is the target of this drug. And with this, what we did is basically trying to measure if the association that we have at the gene level that is measured by a score that is called GDA. This score is given by the source DISNET, that basically measure how a disease is related with a given gene using this score, and this score came from some analysis that they did from literature mining, okay? But this score basically is a good predictor about the relationships that exist between the disease and the gene. And with this, what we were able to see is that the GDI score value, okay, is significantly higher in those pairs of the original diseases and new diseases that were repositioned, in contrast with all the GDAs that we have in DISNET. So basically we can see here, okay, that in the DISNET diseases, we have a GDA value that is around 0.15, something like that. And the difference between this DISNET value and the original disease and the new disease, specifically and the original disease, is much higher, which means that the GDA value can be used as a potential predictor of this hypothesis of repurposing, because the level is higher in the original diseases, but the level is also higher in the reposition ones. And this is really important because we are getting a potential predictor. But we go further. And what we do is that we analyze creating random triples that fulfill the same criteria of having this, I mean, giving a drug, original disease, a new disease, that they share the gene that is in charge of the codification of the target that the drug is going to inhibit or is going to work against it. And we compare the GDI scores of these random triples, 10,000 random triples, with the successful cases that we get in the previous approach, that is these 79, of course, cases that we have the data, okay? And here we have another and even more interesting result. And we could see that the difference in the distribution of the GDI scores, again, is much higher in the original diseases compared with the random disease, the original diseases compared with the random DISNET in the actual, of course, in the actual drug repurposing cases, is higher both in the original and in the new diseases in comparison with the DISNET random triples, okay? And this is really interesting because forcing to make an analysis that is focused on a certain filter, that is that the target should be the same, I mean, the target of a given drug and the target that is, so not the target, sorry, that the protein that is codified by the genes that are in common between these two diseases is forcing that we are working at the same level and we are comparing the same themes. And we saw that in the drug repurposing cases, this value is much higher. We did the same with the Jacquard distance for the symptoms, for the phenotypes, okay? And again, we get the same result. Probably not so higher, but significantly higher in terms of statistics, okay? That the relationships between the DISNET random triples and the drug repurposing that we know that we're repurposing is higher. The distance between the similarities between the two diseases. And this is really important because finally allows us, from both the genes perspective and the phenotypic perspective, show us that the association between the original and the new diseases with the target genes are showing a stronger connection than the mean, okay? Which can allow us to prioritize those diseases with higher genetic association. And finally, my second case is about the COVID-19. And please take into account or bear in mind that this analysis was done at the very beginning of COVID. Now we have much more data. But even with that, the results were interesting. Again, this paper was published in Drug Discovery Today journal. We have more details there. And basically what we did is that we follow five information path approach in order to determine potential drugs that can be used for COVID. How we do that? How we did that, sorry. First of all, we needed to get all the information about COVID. Okay, about COVID, we didn't have too much information, so we decided to introduce two elements that was SARS coronavirus, okay, and MERS coronavirus, and the definition of coronavirus as it, okay, in order to enlarge, because at the end, of course, they are different viruses, but they behave similar and belong to the same family. So with this information, we get all the symptoms for COVID. These are just an example. We get all the genes associated to the COVID, and we start our analysis. Basically, what we got is from COVID symptoms, give me all the drugs that treats these symptoms, and we get 330 drugs. With all the COVID symptoms, give me all the diseases that has at least one of the symptoms, and give me all the drugs that treat these symptoms, these diseases. And we get, 1,800. Third approach, more complex. From the COVID symptoms, give me all the diseases that have these symptoms, give me all the genes from these diseases, give me all the proteins, and give me all the drugs whose target are those proteins. 2,000, more than 2,000 drugs. Fourth path, from the genes of COVID, give me all the diseases that has associated these genes. Of course, one gene is associated with more than one disease, and give me the drugs that are associated to treat those diseases. And the final well, and we get near to 1,800. And the final approach, from the genes, give me the proteins, and give me all the drugs whose target are those proteins, 143. And we combine everything. And we get that in the intersection of these 5 paths, we only have 13 drugs, these ones. And we analyzed these drugs, and we saw that, of course, all of them, well, of course, not necessarily, well, of course, yes, because in the intersection, the 2 final paths are, how to say, are forcing that there is a gene that is involved on that, sorry. But these are the results. We got the therapeutic use. We have many cardiovascular agents, anti-infective agents, also for neoplasm, if I remember, the anti-neoplastic, anti-rheumatic, and all the genes. And here are the results. So what we got is that, to be honest, none of these drugs is now used for COVID. That's a reality. We know that some of them, like hydroxychloroquine, was somehow at some point studied very in depth, but no. But the important thing here, of course, that, well, a better result will be if 1, 2, or even all were finally used. But this is not what we were aiming. Of course, that this could but our aim was using a data-driven approach from our data. Can we go to the same conclusions that many thousands of researchers in the world were also studying, because they arrived to the same feeling, or not feeling, of course, they arrived to the same perspective that these drugs were potential good candidates. And this is the reality. All the drugs were considered for a study for COVID-19, all of them, all of these 13, which means that our approach was able to follow the same path and arrive at the same conclusion, that is, these drugs needs to be further studied. Our approach is not right now, as has been done, is not able to provide conclusions that allows to automatically use the drug in any disease. No, but it's able to provide hypotheses with a solid background, with a solid explanation that allows to tell, okay, this needs to be understood. So finally, as future lines, we are aiming to improve our process. We are aiming to extend the types of biological data. We are aiming to add more network science approaches, and most important, and this is what I get funding for the next 3 years, to apply more complex AI-driven strategies, in this case, graph neural network, for link prediction on our graph in order to study further connections. So that's the reference, and that's all from my side. Thank you very much for your time.
Thank you so much for the keynote. It's very informative. You know, we understand now it's why COVID, 19 is so hard. We get the first information we got is, we only have like 1,200 something drugs. They have so many diseases, and so how can we manage the situation? I don't know, because in Australia it's come to we have, I think, maybe 2 kinds of drugs for COVID-19, but not for everyone, only for a special group like aged people or some other special case. I'm not sure in Spain, but I think your work in the DISNET is very, very interesting. I may give to other audience any questions from the audience.
Professor Wang?
Yep, go ahead.
Can you hear me? Yeah, actually, I have a small question. Professor, I noticed that your platform is like an online framework, like is updating the data connected from all sources, right? So I'm a little bit concerned about the real world application. If some company or some research team is trying to use your platform to test some drugs, but would it be possible that some other people, they will attack your model by inject some false news in Wikipedia because you collected some data from those open source data? And you know, and I know you mentioned before you did some comparison research that the source from the information from Wikipedia is trustworthy, right? But the problem is, I'm wondering if you have this like online watchdog mechanism to keep watching them. Maybe some other person in the future, if this platform is getting influential, people will try to attack, inject some false information. That's possible, right?
Yeah, I mean, this is really interesting. I have never thought about this option, but this is true. You are completely right. Somebody in the future can start modifying the articles automatically about the diseases that is part of our current knowledge, and can make, of course, the system behave different. I completely agree with you in this perception. However, it is true that Wikipedia is one of the sources, and it's not the only one. We have more. And indeed, I mean, what we did with Wikipedia and what I mentioned is that we, because you are completely right, when we started thinking about potential sources, we saw that Wikipedia was really rich in information, but we needed to evaluate it. We evaluated and we saw that they have good results. But the reality is that we have many others. So at some point, part of the decisions that can be made or can be taken from the data that we have can be somehow weighted depending on the source. And this is really, really important. And indeed, and there is one other thing. We have data from the last 3 years. So if right now we start to see, how to say, strange change in the Wikipedia, we can detect it. That's something that can happen. It is true that if there are slight changes, probably cannot be detected. Imagine that you have 2 symptoms. It's part of the normal change of the information in Wikipedia. But I completely agree that this is something that probably we need to pay more attention. In any case, right now, for example, for the analysis that we are doing, it is true that we are still collecting information from Wikipedia, but right now we are not focusing on the new data too much, because what we saw is that most of the diseases are not changing too much. Only in the case of COVID, we saw this change, but of course, because it was a new disease and the people was modifying depending on how the information appears. But in most of the diseases, I mean, in Wikipedia, we can get information from near to 7,000, and I can guarantee you that in most of them, there are no changes, or very, very, very slight changes. And all the information mostly correspond with the other sources. So it is true that can be differences, and it's normal, because again, it depends on the study that is behind, but the changes are very, 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 very little. That's the reality. So it's a possibility, of course. I completely agree with you. Being a public source and so easy to modify, it's a possibility. But in my opinion, the impact will be really, really low, because we already have data, and because if there is a real change, probably we will detect it and we will go through it. But I completely agree with your perspective, and indeed it's really, really interesting. And I take note of this, because it's something that we probably need to pay to take a look and to pay more attention.
Yeah. Because I think this is it's related to a medical issue. So I paid more attention to like the security issue.
Thank you. I agree. Thank you very much for your comment.
Yeah. I think Professor has come to, I think maybe and questions from audience.
Yes, I want to ask a question. Hello, Professor Wang.
Go ahead.
Okay. You got your data from Wikipedia, and on the Wikipedia, not only English. I'm wondering, are you using the multilingual the items from Wikipedia or just English?
Just English. Right now, just English. And it's a very, very interesting question. Indeed, this question emerges very often when I talk about the system, and it's normal. But right now, we are relying, the NLP models that we are using are English ones, because are probably the most robust ones that we have. We work in Spanish, for example. My group is doing NLP in Spanish, but I have to be honest. NLP English models are behaving much better than any other language. It is true that now we have these large language models that probably can work better, but with the current approach, only English, but we didn't discard to open it to other languages using this type of large language models.
Okay, thank you very much.
Thank you.
Yeah, I think you know, when you design the DISNET platform, you have 3 sources, you know, from. So how about the COVID-19 situation? Is the similar, you know, source from there, or you have some other?
No, well, for the COVID-19 analysis, it is true that there is a small variation from the general pipeline. And the reason was that when we started to do this analysis, we found 2 things. The first one is that in the textual sources like Wikipedia, there was more than 1 article talking about coronavirus. When people started to write, they created several. I think that at this point, probably they are merged in one. We force us to do a manual analysis of the data. We couldn't do an automatic, because the platform was not able to catch, you know, the different articles. And the same happens with the genetic data. The genetic data that we rely mainly is DISNET, and DISNET is updated. I think that it's every 6 months or something like that. I don't know exactly the time frame, but it's not so regularly. I mean, it's not weekly or bi-weekly or something like that, which allows, which forces us to use other sources. Basically, we did research on papers, scientific papers, in order to do the analysis, in order to know the genes, in order to know. But once we have all this information, we could go through our system and do the analysis that I presented. But it is true that for COVID, at this moment, we need to do it from other. Right now, we can repeat experiment with all the data in the platform and will work directly, because 2 years after, we already have the data in DISNET, and we can use the sources that I mentioned that we are using in normal research for other diseases. But that's true, completely true.
Great. I think yeah, it's very interesting, you know, topic in here. Yeah. Hopefully one day I can visit your lab.
Of course, all of you are more than invited to, if you want to come to Madrid at some point, and I will be happy to host you here. Yeah, it will be a pleasure.
Great. Let me check the time, as we run a little bit out of the time. If any questions, we have the final questions. You can ask Professor. Good. It looks, I think we don't get any response from audience. So thanks again, Alejandro, and I will contact you later, because we have a record in here, because Agma, and he's traveling, and then I will you know, just pass your talk to him, and and also maybe can share your talk to other conference participants.
No problem. Yeah, of course. Thank you. Thank you again to you for inviting me, and thank you for listening to my work. It has been a pleasure.